So in this next segment, we're now going to transition. So we've gone from definitively treated biochemical recurrence, hormone naive, diagnosed metastatic hormone naive, that most of those patients we know will get ADT and hopefully for higher volume, higher grade disease, some element of an oral agent or chemotherapy. But we know that despite androgen deprivation therapy, which is obviously the baseline of managing these diseases, that ultimately these patients will fail hormone therapy, and we will get into this area called castration-resistant prostate cancer. So, Neal, for the audience, give us a working definition of castration-resistant prostate cancer.
Yeah, I mean, we've gone through all these iterations of various nomenclature, verbiage, and it's still controversial, but I think some folks don't really like and they bristle about this word castration. Maybe some would like some other definition for it. But that said, I think it's gotten its traction because of the trials that we've done. And it's been important, and I think the prostate cancer working groups 1, 2, and 3 have been really helpful in standardizing global trials. And so the definition that's fairly ubiquitously used is you have to check a testosterone level. It has to be, at least in our metrics here in North America, less than 50 nanogram per deciliter, usually repeated, ideally, possibly a second time, but not always, doesn't have to be. The PSA has to be rising at least by 25% or more from the nadir, and then repeated a second time. I think in real world practice, most of us would accept the fact, as long as the PSA is going up from nadir and the T level is less than 50 nanogram per deciliter, then that indeed is CRPC.
Yeah, I would just clarify, because we see these cases with these slightly higher testosterone levels, and I'm sure you guys have seen these too, where the patients are on an LHRH agonist, and yet the testosterone is 60 or 65. And to me, that's still castration resistant. We draw the line of 50 because we have to, right? We have to draw it somewhere. But to me, it's more of a guideline. If I've had a patient on an LHRH agonist, and whatever their T has gone down to, their PSA has dropped. And now they've gone from a nadir and they're going up. They're still on that LHRH agonist. For me, for all intents and purposes, that's going to be castration resistant, even if the T is a little bit higher. So we've actually gone to raising that threshold to 75 in some of our protocols, just because we've run into this issue. And we run into it in some of our minority populations sometimes, in other populations that I don't really know how to explain it. But I don't know that it is fundamentally going to prevent us from getting to castrate resistance, because I don't know how to lower it lower. I've done surgical castration.
Well, Dan, what is the utility, for instance, of switching over to a degarelix to try to see if you could reverse that trend?
It's a good point, Alex, and we've tried that, and I'll say some of the times it works, but not all the time. So it's, I don't want to get too stuck on it. I mean, I think the intent is, and most of the patients are less than 50, but it does. It's not a perfect definition.
Well, so you said those are just your investigator-initiated protocols,
Sure.
but unfortunately, it's pretty rigorous. If you don't get somebody below 50, that's oftentimes for most trials an exclusionary criteria. I think you're right. I think sometimes you can try a different agent, a different LHRH agonist, antagonist, bilateral archaectomy. But I would also suggest look at your testosterone assay. They're starting to see a lot of different assays out there, and so that some of those can be misleading. I mean, still today, mass spec is going to give you the best number. So I don't know if you've seen we've seen this variability. So I would advise the audience to think about where you're getting the T assay.
It's a good point. I would just say it's all kind of arbitrary. At the end of the day, I don't want people to hold back on using drugs for castrate resistance because of something like this. So if you don't have access to those kind of things, I don't want you to feel restricted by it.